Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arora, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 415 of our pharmacotherapy series, which majors in lower gastrointestinal disorders. The next clinical case reads: VSH is a 33-year-old woman who presents with complaints of severe abdominal pain, rated 6 on a scale of 1 to 10, bloating, and the passage of hard pellet-like stools about every 3 days. This has gone on for about 6 months, and VSH notices that an attack occurs usually after a large meal. Her past medical history is significant for a generalized anxiety disorder. Her current medications include buspirone and Yaz, i.e. drospirenone and ethinyl estradiol. She drinks socially and does not smoke or use illicit drugs. VSH is concerned that her symptoms are indicative of cancer. So my first question to you reads: how should the clinician respond to VSH's concerns? Clinicians must reassure patients with irritable bowel syndrome, abbreviated as IBS, that their symptoms are real but benign. An effective physician-patient relationship is important for improved patient satisfaction, adherence to therapy, and symptom reduction. Furthermore, patients should be thoroughly counseled concerning the prognosis of irritable bowel syndrome. Many patients are fearful that their symptoms are indicative of severe pathology such as cancer. Reassurance and education are vital to assuage fears and to reinforce the generally benign nature of this disorder. Involving patients at the earliest stages in their treatment plan is vital for patient acceptance and to avoid doctor shopping. Further, some patients exhibit a phenomenon known as somatization. This is defined as a tendency to experience and communicate somatic distress in response to psychosocial stress, and is a factor in how often irritable bowel syndrome patients seek healthcare for their condition. Educational sessions and psychological techniques are thought to decrease the risk of developing somatization, but data to date are limited concerning these interventions. Unfortunately, psychological disorders are present in a large segment of irritable bowel syndrome patients. The clinician should again reinforce the notion that irritable bowel syndrome is not all in the patient's head. However, treatment of comorbid disorders, including the discovery of a history of physical or sexual abuse, and possible post-traumatic stress disorder, is an important component in successfully treating irritable bowel syndrome. Thus, the initial intervention with patients of irritable bowel syndrome should include an interactive patient education session of irritable bowel syndrome and earning the patient's trust. We will now look at diet and probiotics. Food intolerance may cause symptoms similar to those associated with irritable bowel syndrome. Patients with lactose intolerance can experience pain, bloating, and diarrhea after ingesting milk-based products. A dietary and symptom diary may reveal such an intolerance, and avoidance of the implicated foods would constitute effective treatment. Unfortunately, most patients with irritable bowel syndrome have difficulty complying with exclusion diets or will not achieve significant relief with them. Gluten-free diets eliminate gluten found in wheat, barley, and rye and a wide variety of processed foods, while FODMAPs diets consist of eliminating a group of short-chain carbohydrates such as fermentable oligosaccharides, disaccharides, monosaccharides, and polyols called FODMAPs, because they are unable to be properly absorbed by patients with irritable bowel syndrome and cause fermentation by bacteria in the gut producing gas. Recent guidelines suggest that gluten-free and low FODMAPs diets show promise, but their role is still questionable. Guidelines also suggest there is not enough data to recommend prebiotics or symbiotics. However, probiotics have shown promise with a decrease in flatulence or bloating, although there are no comparative studies to suggest one product over another. VSH has gradually increased her dietary fiber, mainly bran, during the past 6 weeks. She still feels constipated and did not experience any improvement. In addition, new symptoms of abdominal bloating have occurred in the past week. My next question to you reads: what is a reasonable strategy to treat VSH's irritable bowel syndrome with constipation? Patients with irritable bowel syndrome with constipation may benefit from increased dietary consumption of soluble fiber, with a recent study finding that psyllium significantly improved irritable bowel syndrome symptoms during 3 months of treatment compared with placebo. Insoluble fiber such as bran can worsen symptoms of bloating, cramping, or flatulence. Patients should be counseled that large doses of fiber can lead to abdominal gas and bloating, and overall objective long-term evidence in irritable bowel syndrome is lacking. VSH should be encouraged to keep a food diary to identify food intolerances. Currently, there is very little evidence to suggest a gluten-free or a FODMAPs diet for this patient. She can consider probiotics, but there is insufficient evidence to suggest one probiotic over the other. When choosing fiber for constipation, she should substitute bran fiber for soluble fiber, such as psyllium, to reduce abdominal gas and bloating. Several months have passed since VSH was first diagnosed with irritable bowel syndrome with constipation. She has had therapeutic trials of several over-the-counter agents that were either poorly tolerated or lacked effectiveness. My next question to you reads: what other options are available for treating VSH's irritable bowel syndrome with constipation? Let's take a closer look at pharmacotherapy for irritable bowel syndrome with constipation, abbreviated as IBS-C. In patients with irritable bowel syndrome with constipation in whom fiber therapy fails, other standard laxatives may be tried for symptomatic relief. These may include milk of magnesia, lactulose, senna, or polyethylene glycol without electrolytes, marketed as Miralax. This last agent was shown to improve the number of bowel movements in a cohort of adolescents with irritable bowel syndrome with constipation, but had no effect on abdominal pain or bloating. Few well-designed trials looking at any laxative for irritable bowel syndrome have been published. These agents are usually well tolerated, although they can occasionally cause abdominal bloating. Other adverse effects of the osmotic laxatives include diarrhea, taste disturbances, and hypermagnesemia, especially in patients with renal impairment. Although laxatives may provide relief of constipation, they will not effectively treat abdominal pain. Thus, other treatments will be required in many patients. We will now look at tegaseride. Stimulation of the 5-HT4 receptor accelerates colonic transit and has been exploited as a target for pharmacotherapy of irritable bowel syndrome with constipation. The first of these agents, tegaseride, was originally approved in the United States for women with irritable bowel syndrome with constipation. Tegaseride is a specific 5-HT4 partial agonist that was evaluated in women with at least a 3-month history of irritable bowel syndrome with constipation symptoms. Clinical studies demonstrated a modest but significant benefit with tegaseride. Unfortunately, post-marketing analysis by the U.S. Food and Drug Administration found an increased incidence of heart attack, stroke, and unstable angina in patients receiving the drug, and in April 2008, the manufacturer of tegaseride halted all sales and marketing of this agent. And now we will discuss lubiprostone. Lubiprostone, a gastrointestinal chloride channel activator, i.e. CIC2 channels, that enhances intestinal fluid secretion and acts as a laxative, was approved in the United States for irritable bowel syndrome with constipation in women older than 18 years of age. The drug has several actions on gastrointestinal function, including increased small and large bowel transit time and decreased gastric emptying. The dose of lubiprostone for irritable bowel syndrome with constipation is 8 micrograms orally twice daily with food and water, which is a lower dose than used for chronic idiopathic constipation. Mechanical gastrointestinal obstruction is a contraindication to lubiprostone's use. A recent analysis of 2 randomized controlled studies of lubiprostone versus placebo in women with irritable bowel syndrome with constipation found that the drug was moderately effective in improving patient perception of constipation symptoms, 17.9% versus 10.1% of placebo groups responded, with a p-value equal to 0.001. Primary adverse effects of lubiprostone include nausea and vomiting, but the effects are less likely at the dose of the drug approved for irritable bowel syndrome with constipation and can be somewhat ameliorated by taking the medication with food. Too few men with irritable bowel syndrome with constipation were enrolled in the clinical trials with lubiprostone to draw any conclusions about its effectiveness in this population. Because the drug is associated with teratogenic effects in animals, the manufacturer recommends that women who could become pregnant have a negative pregnancy test before beginning therapy and be able to comply with effective contraceptive measures during therapy. The drug is significantly more expensive than traditional laxatives, and should generally be reserved for patients who have failed other therapy for irritable bowel syndrome with constipation. Next we will talk about linaclotide. Linaclotide, marketed as Linzess, is a guanylate cyclase C agonist and together with its active metabolite bind to guanylate cyclase receptors, acting locally on the luminal surface of the intestinal epithelium to increase intracellular and extracellular cyclic guanosine monophosphate, CGMP, concentrations. Elevated cyclic guanosine monophosphate stimulates chloride and bicarbonate secretions into the intestinal lumen, resulting in increased intestinal fluid and gastrointestinal movement with decreased response to pain. Linaclotide's approval was based on 2 randomized, double-blind, placebo-controlled phase 3 trials. Results from clinical trials show that patients receiving linaclotide reported small, but statistically significant improvements in abdominal pain, discomfort, and bloating, with some improvements in bowel straining, constipation, and stool consistency compared to placebo-treated patients. On withdrawal of linaclotide therapy, abdominal pain returned and bowel movements decreased to levels similar to the placebo group, but there was no rebound effect noted. Linaclotide is approved for use in male and female adult patients older than 18 years at a dosage of 290 micrograms daily, taken 30 minutes before breakfast. There is a boxed warning for contraindicated use in children less than 6 years old and patients with known or suspected mechanical gastrointestinal obstruction. Use should be avoided in children 6 to 17 years because of deaths from dehydration in younger juvenile mice. Because of low systemic exposure, drug interactions are unlikely. The main side effect is diarrhea, abdominal pain, and flatulence. Because there are no head-to-head comparative trials with lubiprostone and linaclotide, both of these agents are viable options for VSH. Therefore, a trial of lubiprostone 8 microgram orally twice daily with meals, or linaclotide 290 microgram daily taken 30 minutes before breakfast would be reasonable. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it, and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 416.